Back to our channel. In this video we are going to discuss about congenital malformations. So first we need to understand what is congenital malformation, that is the defects which are coming from the time of birth. So here mainly we are going to discuss about the Mullerian duct malformation. Mullerian duct is called as paramesonephric duct and Wolffian duct is called as mesonephric duct. We have discussed this already. So let us discuss mainly about this. Before that, let us start the relevant anatomy related to this. You know that by 6 weeks in all fetus, both the ducts are present. Like the Mullerian duct, Wolffian duct is present because by 6 weeks it is not divided into either male or female. But by 9 weeks, one duct disappears. That is, in the case of female, Wolffian duct disappears, whereas in the case of male, Mullerian duct disappears. Okay, so by 20 weeks, the internal genitalia are formed in female. Mainly, they are formed by Mullerian duct. So this is the anatomy which you need to understand to start our topic today. So let us start the formation of various internal genital organs, especially in female. So female. First it looks like this. And next it start forming. So this is a Mullerian duct. So this side it divides to form a left fallopian tube, and this side it forms a right fallopian tube, and in the middle it forms a uterus here, and here it forms a cervix, and of course below it forms a vagina. So this is how the Mullerian duct differentiate into different parts in adults. So the fusion begins in the below upward direction. Actually, this structures should fuse now and form a structures. So the fusion begins from below downwards like this. From below it will go to upwards, and after that there is formation of septa, and the septa also should fuse so that a cavity forms. So the septa fusion will begin at 20 weeks. That is also called as septa resolution, and it is also going on from below upwards. Next, coming to fundus becomes dome shape. You can see here the dome shape fundus. So this is how the fundus is forming. This is the dome shaped fundus of the uterus. Now coming to uterus. Uterus is formed by 10 weeks. So uterus is formed on 10 weeks, but the uterine cavity, the cavity inside is formed by 20 weeks, because the septa resolution takes place at 20 weeks, then only the uterine cavity is also formed. So defects in the fusion of Mullerian duct is known as lateral fusion defects. So lateral fusion defects, that is the Mullerian malformations. Okay. So Mullerian malformation is the first investigation which you want to do when you suspect the Mullerian malformation, is immediately you do the HSG. So HSG is nothing but hysterosalpingography. Let me write it here. Hysterosalpingography. So hysterosalpingography is a procedure which you need to do to find out the Mullerian malformations. So for this, what we will do? Actually, you can take this example of a uterus. Okay, so we are going to pass a radio opaque dye into the uterus, and you follow up with the serial X-ray. Okay, and you will follow up with X-ray. The instrument which you use here is called as Leach Wilkinson cannula. What is that? Leach Wilkinson cannula. So Leach Wilkinson cannula is a funnel shaped end with a transverse striations. So let me draw that. For example, like this, it will be with transverse striations. So this cannula will put inside the vagina of a female, so that the dye will pass into all the structures, and if that dye is passing, then you can find out like how many vagina are there, how many cervix are there, how many fallopian tubes are there, what is the shape of the uterus. So that is why we do this test. Okay. And the time when you do this test is especially the pre-ovulatory phase, because when you do in ovulatory phase, if a female by mistake becomes pregnant, then that will lead to abortion. So to prevent that, always we want to do in a reproductive female in a pre-ovulatory phase, that is from day 7 to day 10 of menstrual cycle. So according to day 7 to day 10 of menstrual cycle, you will do this procedure, that is hysterosalpingography. In the name itself, you can see salpingo means it is referring to fallopian tubes, hystero means it is referring to uterus. So this color, the dye is going to the uterus and also to the fallopian tubes, hence the name is like that. Okay. So, all radiological investigations in a reproductive age, female are done in a pre-ovulatory phase, that is day 7 to day 10 of the cycle. So, what are the contraindications for this HSG test? The contraindications are we should not do this test in an active PID, that is, whenever there is active pelvic inflammatory disease. If you do this test, you can understand because of this dye, even this infection will go and pass to this all structures. So, in that case, we should not do. And in the case of active TB, so whenever there is a TB infection, this is also having a chance of spreading. And whenever there is a pregnant female, don't do this, of course, because it will lead to abortion in pregnant female. So always remember that investigation of choice. You may think that now we are talking about HSG, so this may be investigation of choice, but no, it is not an investigation of choice in Mullerian malformation. Because HSG cannot differentiate between the bicornuate and septate uterus. So what is bicornuate and septate uterus? I am going to show them now. Okay. So let us come to the important topic, that is various malformations. So you have class from class 1 to like almost class 7. You have total 7 classes to show different Mullerian malformations in a female. So let us discuss them one by one. So first class. You can see this is actually given by ASRM. ASRM means American Society for Reproductive Medicine has given these classes. So the first class mainly represents the both Mullerian ducts are absent. So you can understand now, as I said, if both Mullerian ducts are present, then this all structures are formed. So now we have no Mullerian duct. So what happens when there is no Mullerian duct? That will lead to Mullerian agenesis. You can see both ducts are absent, so that is leading to Mullerian agenesis, which is also called as MRKH syndrome. So what is the full form of this MRKH? M means Mayer, R means Rokitansky, K means Custer, H means Hauser. So Mayer Rokitansky Custer Hauser syndrome. So the ovaries are present here because ovaries generally develop from genital ridge. If Mullerian agenesis means the remaining parts like lower part of vagina is also normal because it will develop from urogenital sinus. But the fallopian tubes, uterus, so fallopian tubes, uterus, cervix will not form, and even the upper part of vagina will not form, but the lower part of vagina will be forming and ovaries are formed because lower part of vagina is formed from urogenital sinus, which is of endodermal origin, and ovaries are also present because they are developing from genital ridge. Now coming to class 2. In class 2, the problem is the Mullerian duct is present only on one side and absent on other side. So only one side is present. So what happens? Only one side structures will be forming. Hence the name is unicornate uterus. So unicornate uterus is class 2 type where only one side of Mullerian duct is present. So because of this, there is only one fallopian tube. And uterus is also formed, only half of the uterus is formed, and cervix also half of the cervix is formed, and upper vagina also half of it is formed. Of course lower vagina will form completely because it is from urogenital sinus. Okay, so sometimes it is also associated with rudimentary on. So sometimes in this unicornate uterus, it is associated with rudimentary HOD, then it will also lead to endometriosis. So it is associated with endometriosis, and also it is associated with unilateral dysmenorrhea. That is, there is there is no bleeding from one side. Okay, and especially during menstruation, and ectopic pregnancy because only half side is present, right? And also it may lead to ectopic ovary. And also it may lead to some renal abnormalities or like some renal anomalies because Mullerian duct also forms some part of the renal parts, right? So if half only is present, then half of the renal system only will be present, so that will lead to renal abnormalities in the case of unicornate uterus. So this is what you need to see about unicornate uterus. And in the HSG also you can see that only one fallopian tube and a banana shaped uterus. You will see a banana shaped uterus and only you will see like this one side of fallopian tube because it is a unicornate uterus. So we have completed class 2. Okay, so now coming to the protocol to diagnose uterine anomalies on HSC. So what you will follow to identify the HSC. For example, take this as an HSC graph. So the first thing you need to see is external contour. You see like external outside features, everything is normal or not. And the second thing which you need to see is the number of fallopian tubes. You can see here, for example, 2 fallopian tubes, right? It is normal. And third thing you need to see is number of uterine cavities because sometimes there may be two uterine cavities, right? So you can see in a normal there is only one uterine cavity which is forming by 20th week. So okay, so next coming to fourth thing which you need to see is the cervix. You should see whether the cervix is single or double. Okay, so this is the order. First, external contour, second, number of fallopian tubes, and the third one is uterine cavity, and the fourth one is cervix. So this is how you need to check out the structures one by one. So now coming to class 3 and 4. So coming to class 3. In class 3, here both Mullerian ducts are absent, here both Mullerian ducts are present, but they are not fusing. So there is no fusion. So failure of Mullerian duct to fuse in entire length. And this type of uterus is called didelphic uterus, because you can see they are not fusing, they are staying like this only. So two uterus. So you will be having didelphic uterus, and also you will be having uh, two fallopian tubes. It's normal, okay. Two uterus and two cervix. You can see here two cervix, two cervix. So two cervix is a hallmark feature for class 3, and only you will have one vagina, or you may have two vagina, like because the septum is still present. So there is a one vagina with single septum, you can say, or you can say two vagina are formed with the septum, okay. So for this type of investigation in HSG, you need to put two cannulas, because you can say two vaginas, two cervix, so you need to send two cannulas. So whenever on a HSG you see two cannulas, then you can say it is a didelphous uterus, okay. So now coming to class 4. So you can see here class 4. Class 4 is that both Mullerian ducts are present and the fusion begins, but it is incomplete. So fusion is incomplete and both ducts are present here, and the fusion begins from caudal end. Always the fusion begins from caudal end, and it ends in a cranial end, and always a single fusion and it is having always a single cervix. So here the differentiation between the class 3 and class 4, that is the didelphous uterus and the bicornuate, this is called as bicornuate uterus. The difference is here only one cervix, there are two cervix. So whenever you see two cervix, that is didelphous. Here bicornuate, only one cervix but two uterine cavities, one vagina. So this is called as bicornuate uterus, okay. So remember here it has two fallopian tubes, two uterine cavities. I have drawn this diagram, you can see two fallopian tubes, two uterine cavities, only one cervix and only one vagina, and abnormal external, you can see some abnormality externally also, okay. So finally coming to class 5. Here you can see the class 5. In the class 5, both the Mullerian ducts are present, but the fusion is incomplete. So the fusion occurs and septa forms, and that septa fails to resolve. So the septa is failing to resolve, like this, a septa is present. Okay, so this is called as septate uterus, and this septate uterus either may be complete or incomplete. Complete septate uterus will look like this. Incomplete means it is not going till lower, the septa will be only upper side, only it is present upper part, so that is called as incomplete septate uterus, okay. So in the septate uterus also you will find two uterine cavities, you will see only single cervix, and you will see normal external appearance. So in the case of bicornuate and also in the case of septate uterus, you are seeing a normal in a bicornuate uterus you will see abnormal external appearance, whereas in the case of septate you will see normal external appearance, okay. So let us differentiate between this class 4 and class 5, that is between bicornuate and septate uterus. In both this you have only single surface, and in both you are having two uterine cavities. So how to differentiate them? In the case of external contour in bicornuate, it is abnormal. So this external contour is abnormal. Here it is normal in class 5. And upon HSG both look same, so they can be differentiated by certain criteria. Like if you put the dye, okay, you should see that in a bicornuate uterus the distance is greater than 4 centimeters and the angle is greater than 60 centimeters here between the two uh, uterus. Here the distance, if you see the distance here, it is less than 4 centimeters and the angle is also less than 60 degrees, then you can confirm it as our septate uterus, right? Now coming to class 6. In class 6 everything is normal, but the problem is the fundus of the uterus is not become dome shaped, and the fundus starting becoming dome shaped, but there is a dimple in the center. So that is called as arcuate uterus. For example, this is uterus, you will see just a small dimple like structure and it is flat here above. So this type of uterus is called as arcuate uterus, okay. And The fundus started becoming dome shape, a dimple in the center, and this is the best reproductive prognosis because here everything is normal, just a dimple has formed. Okay, so coming to class 7. Class 7, the last class, is a congenital problems due to exposure to DES. What is this DES? DES means diethyl stilbestrol. Diethyl stilbestrol. So because of this, if a mother is taking this type of drugs, then our mother is exposed to it, then it will lead to congenital problems. And here it is different in male and female. In the case of female, you will see mainly the uterus is hypoplastic, which is the most common, and you will see the T-shaped uterus, which is most characteristic. And also you will see the cervical collars or hoods. And also you can see two types of cancers in this fetus, like it is a adenocarcinoma of the cervix or clear cell carcinoma of vagina. And remember that there is never renal anomalies seen in the case of female fetus with DES exposure or class 7. So coming to male fetus, male will have hypospadias, and also male will have cryptocorchidism, and also there will be testicular hypoplasia, and this can lead to renal anomalies. So renal anomalies are present in male fetus, but renal anomalies are not present in the female fetus. Now coming finally to the general points. The general points is the most common Mullerian abnormality or anomaly is septate uterus greater than bicornuate uterus. The first investigation which you do is TVS. After doing TVS, you will do HSG. And the investigation of choice is 3D USG. And the gold standard which you can do is MRI. Now coming to Mullerian malformations, which can lead to problems in different pregnancy, like recurrent abortions, especially in second trimester, or it can lead to intrauterine growth restriction and also malpresentation like breech position, and also it can lead to preterm labor. So these are general points related with Mullerian malformation. Next, coming to Mullerian malformation is associated with worst prognosis, worst reproductive outcome is septate uterus. Septate uterus is greater than unicornate uterus. Next, the Mullerian malformation which is associated with best reproductive outcome is arcuate uterus. Next, coming to Mullerian malformation which is associated with renal anomalies. So already we discussed the unicornate uterus is associated with renal anomalies. So what is the indication of management? So how to manage this patient? Like what is the indication to manage this patient? When a patient is having more than 3 recurrent abortions, then we can indicate that because of Mullerian malformation this is going on. So we need to go for a surgery. So what kind of surgery we can do? We can do septate surgery, or we can do a bicornuate unification surgery. So first let us discuss in the septate uterus what kind of surgery we do. We do hysteroscopic resection. We do hysteroscopic resection of septa, or we can do a transcervical resection of septa. So these two surgeries are done earlier in the septate uterus, but earlier there are different methods like John's metroplasty or Tompkins metroplasty, but this John's and Tompkins metroplasty are not done nowadays, and nowadays we only do the hysteroscopic resection and also transcervical resection. So coming to bicornuate or didelphus uterus, in this type of uterus we are going to do the unification surgery, or we can do the Strassman metroplasty. So Strassman metroplasty unification surgery are done in bicornuate didelphus uterus. Now coming to hysteroscopy. So in hysteroscopy we are going to use a distension media. So hysteroscopy is divided into operative type and diagnostic type. So actually we are using a distension media. In the case of diagnostic we use a carbon dioxide for the distension, and in the case of operative we are going to use a fluid as distension. And this operative type is divided into two types. One is electrolyte rich, one is electrolyte poor. So electrolyte rich one we can use lingual lactate and normal saline, and here hyponatremia is not seen, and it is only used bipolar cautery. Whereas electrolyte deficient, where we use glycine 1.5, which is most common, and sorbitol 3%, mannitol 5%, and here we use bipolar and unipolar cautery. So here only bipolar, here bipolar plus unipolar cautery, and the fluid overload, because of that it will lead to hyponatremia. So here there is no hyponatremia, but here there is hyponatremia and electrolyte deficient. So coming to fluid deficient. The difference between outgoing fluid volume and ingoing fluid volume. You can see this is a uterus, this is a difference outcome between the incoming fluid and outcoming. You can see this is the income, this is the outcome. So if the difference between outgoing and ingoing volume, the electrolyte deficient media, you can see here that is a fluid deficient. If it is greater than 1 liter, then you need to stop. If the electrolyte rich media, the fluid deficient is greater than 2.5 liter, then you need to stop. In electrolyte deficient, here electrolyte rich. So these are the indications which you need to see. By this we completed congenital malformations. Next we'll start with puberty.